Today we will discuss about Claritek, which contain clarithromycin. Description: Clarithromycin is a semisynthetic macrolide antibiotic obtained by substitution of the hydroxyl group in position 6 by a CH3O group in the erythromycin lactonic ring. The molecular formula is C38H69No13. Qualitative and quantitative composition: clarithromycin. Clarithromycin is available for oral administration as clarithromycin 250 mg tablet, clarithromycin 500 mg tablet, clarithromycin 125 mg per 5 ml granules, clarithromycin drops 125 mg per 5 ml, clarithromycin dry suspension 250 mg per 5 ml. Clinical pharmacology. Mechanism of action: clarithromycin exerts its antibacterial action by binding to the 50S ribosomal subunit of susceptible bacteria and suppresses protein synthesis. It is highly potent against a wide variety of aerobic and anaerobic gram-positive and gram-negative organisms. Microbiology. Clarithromycin has shown to be active against the following microorganisms. Aerobic gram-positive microorganisms: Staphylococcus aureus, Streptococcus pneumoniae, Streptococcus pyogenes, Listeria monocytogenes. Aerobic gram-negative microorganisms: Haemophilus influenza, Haemophilus parainfluenza, Moraxella catarrhalis, Neisseria gonorrhea, Legionella spp, for example Legionella pneumophila. Mycobacteria: Mycobacterium leprae, Mycobacterium cansazii, Mycobacterium kelloni, Mycobacterium fortuitum, Mycobacterium avium complex MAC. Consisting of Mycobacterium avium, Mycobacterium intracellulare, Helicobacter, Helicobacter pylori. Other microorganisms: Mycoplasma pneumoniae, Chlamydia pneumoniae, Chlamydia trachomatis, Ureaplasma ureolytium, Protozoan, Toxoplasma gondii. Pharmacokinetics. Absorption. Clarithromycin is rapidly and well absorbed from the gastrointestinal tract but undergoes extensive first-pass metabolism after oral administration. The absolute bioavailability of a 250 mg clarithromycin tablet is approximately 50%. The bioavailability of the suspension is identical to or slightly higher than the bioavailability of the tablets. The pharmacokinetic profile of the suspension in children corresponds to the pharmacokinetic profile of the suspension in adults. Due to its chemical structure, 6-O-methyl-erythromycin, clarithromycin is quite resistant to degradation by stomach acid. After oral administration of 250 mg and 500 mg clarithromycin twice daily, peak plasma levels of 1 to 2 microgram per milliliter and 2.8 microgram per milliliter were observed respectively in adults. The peak plasma concentration of pharmacological active 14-hydroxy metabolite was 0.6 microgram per milliliter after the administration of 250 mg clarithromycin twice daily. Steady state is attained within 2 days of dosing. Effect of food. Food slightly delays the absorption of clarithromycin but does not affect the extent of bioavailability, therefore it may be given without regard to food. Distribution. Clarithromycin penetrates well into different compartments, with an estimated volume of distribution of 200 to 400 liter. Clarithromycin provides concentrations in some tissues that are several times higher than the circulating level of the active substance. Increased levels have been found in both tonsils and lung tissues. Clarithromycin also penetrates the gastric mucus. Clarithromycin is approximately 80% bound to plasma proteins at therapeutic levels. Metabolism. Clarithromycin is rapidly and extensively metabolized in the liver. Metabolism involves mainly endalkylation, oxidation and stereospecific hydroxylation at position C14. Excretion. Clarithromycin is excreted in the feces, 5 to 10%, via the bile. At steady state approximately 20% and 30% of clarithromycin is excreted as unchanged drug in urine. 14-hydroxychlorothromycin as well as other metabolites are also excreted in the urine, accounting for 10% to 15% of the dose. The elimination half-life of chlorothromycin is reportedly about 3 to 4 hours in patients receiving 250 mg doses twice daily, and about 5 to 7 hours in those receiving 500 mg twice daily. The principal metabolite, 14-O-chlorothromycin, has an elimination half-life of 5 to 6 hours after a dose of 250 mg twice daily and about 7 to 9 hours in those receiving 500 mg twice daily. Special populations. Renal impairment. The plasma levels, half-life, Cmax and Cmin for both chlorothromycin and its 14-O metabolite were higher and the area under curve was larger in subjects with renal impairment. Geriatric, elderly patients with severe renal impairment may require dose adjustment. Therapeutic indications. Chlorothromycin is indicated for treatment of infections due to susceptible organisms. Such infections include lower respiratory tract infections, for example, bronchitis, pneumonia. Upper respiratory tract infections, for example, pharyngitis, sinusitis, tonsillitis. Acute otitis media in children. Skin and soft tissue infections, for example, folliculitis, cellulitis, erysipelas, impetigo, abscesses. Disseminated or localized mycobacterial infections due to MAC. To eradicate Helicobacter pylori in treatment regimens for peptic ulcer disease. To prevent disseminated Mycobacterium avium complex, MAC, disease in patients with advanced HIV infection. As an alternative treatment to penicillins for prophylaxis of endocarditis. Dosage and administration. Adults. The usual recommended dosage of chlorothromycin is 250 mg tablet twice daily. In more severe infections, the dosage can be increased to 500 mg twice daily. The usual duration of therapy is 6 to 14 days. Children, the usual recommended daily dosage of chlorothromycin suspension is 7.5 mg per kg/d up to a maximum of 500 mg twice daily. The usual duration of treatment is 5 to 10 days depending on the pathogen involved and the severity of the condition. Dosage for the eradication of H. pylori associated with peptic ulcer disease, chlorothromycin, usually in a dose of 500 mg twice daily, is given with another antibacterial and either a proton pump inhibitor or a histamine H2 receptor antagonist, for 7 to 14 days. Dosage for mycobacterial infections. For adults, chlorothromycin is recommended as the primary agent for the prophylaxis and treatment of disseminated infection due to Mycobacterium avium complex. Chlorothromycin should be used in combination with other antimycobacterial drugs that have shown in vitro activity against Mycobacterium avium complex or clinical benefit in Mycobacterium avium complex treatment. The recommended dose for mycobacterial infections in adults is 500 mg BID. For children, in children, the recommended dose is 7.5 mg per kg/d up to 500 mg BID. Dosing recommendations for children. Renal impaired patients, the maximum recommended dosages should be reduced proportionately to renal impairment. At creatinine clearance rate of less than 30 ml per minute, the dosage should be halved to 250 mg daily, or in the most severe infections to 250 mg twice daily for adults and 7.5 mg per kg once a day for children. The duration of treatment should not exceed 14 days in these patients. Direction for reconstitution: fill previously boiled and cooled water up to the mark on the bottle and shake well. After mixing, do not refrigerate. Keep tightly closed after use. Contraindications: chlorothromycin is contraindicated in patients with known hypersensitivity to the active substance, other macrolide antibiotics, or to any of the excipients. Concomitant administration of chlorothromycin with any of the following medicines is contraindicated: estimazole, cisapride, pymazide, and terfenadine. Concomitant administration of chlorothromycin with ergot derivatives is contraindicated. Adverse reactions. The following side effects were reported with the use of chlorothromycin. Common: oral manilia, headache, smell alteration, nausea, diarrhea, vomiting, abdominal pain, dyspepsia, stomatitis, glossitis, reversible tooth and tongue discoloration, and taste perversion, i.e. metallic or bitter taste. Uncommon, decreased leukocyte levels, allergic reactions ranging from urticaria and mild skin eruptions to anaphylaxis, hepatic dysfunction which is usually transient and reversible, hepatitis and cholestasis with or without jaundice, arthralgia and myalgia. Rare, tinnitus. Very rare, thrombocytopenia, anxiety, insomnia, hallucinations, psychosis, disorientation, depersonalization, bad dreams and confusion, dizziness, vertigo, paresthesia, convulsions, reversible hearing loss, QT prolongation, ventricular tachycardia and torsades de pointes, pancreatitis, pseudomembranous colitis in range of severity from mild to life-threatening, fatal hepatic failure in patients with pre-existing liver disease or taking other hepatotoxic medicinal products, Stevens-Johnson syndrome, toxic epidermal necrolysis, interstitial nephritis, and renal failure. Precautions. Caution should be taken in administering clarithromycin to patients with impaired hepatic function. Caution should also be paid to the possibility of cross-resistances between clarithromycin and other macrolide drugs, as well as lincomycin and clindamycin. Pseudomembranous colitis has been reported with the use of broad-spectrum antibiotics. Therefore, it is important to consider its diagnosis in patients who develop severe diarrhea during or after therapy with clarithromycin. Prolonged or repeated use of clarithromycin may result in superinfections within susceptible organisms. In case of superinfection, clarithromycin therapy should be stopped. Clarithromycin should be used with caution whenever indicated for use in patients receiving treatment with an inducer of cytochrome P3A4. Clarithromycin in combination with ranitidine bismuth citrate therapy should not be used in patients with a history of acute porphyria. Clarithromycin is an inhibitor of the metabolizing enzyme cytochrome P3A4 should not be used concomitantly with different cytochrome P3A4 substrates unless plasma levels, therapeutic effect, or adverse events of the cytochrome P3A4 substrate are closely monitored. Pregnancy. There are no adequate or well-controlled studies in pregnant women. Clarithromycin should be used during pregnancy only if the potential benefit justifies the potential risk to the fetus. Nursing mothers. Clarithromycin and its active metabolite are excreted in breast milk. Therefore, diarrhea and fungus infection of the mucous membranes could occur in the breastfed infant, so that nursing might have to be discontinued. The possibility of sensitization should be borne in mind. The benefit of treatment of the mother should be weighed against the potential risk for the infant. Drug interactions. Digoxin. Elevated digoxin serum concentrations have been reported in patients receiving clarithromycin and digoxin concomitantly. Monitoring of serum digoxin levels should be considered. Quinidine per diisopyramide. Concurrent use of clarithromycin and quinidine or disopyramide may cause torsades de pointes. Electrocardiogram and serum levels of these medications should be monitored during clarithromycin therapy. Hemillogram CoA reductase inhibitors. As with other macrolides, clarithromycin has been reported to increase concentrations of hemillogram CoA reductase inhibitors, e.g. statins. Rare reports of rhabdomyolysis. Rhabdomyolysis is a potentially life-threatening syndrome resulting from the breakdown of skeletal muscle fibers with leakage of muscle contents into the circulation, have been reported in patients taking these drugs concomitantly. Zidovudine. Simultaneous oral administration of clarithromycin tablets and zidovudine to HIV-infected adult patients may result in decreased steady-state zidovudine concentrations. This interaction does not appear to occur in pediatric HIV-infected patients taking clarithromycin suspension with zidovudine or dideoxyinacine. Ritonavir. Concomitant administration of clarithromycin and ritonavir resulted in a 77% increase in clarithromycin AUC and a 100% decrease in the AUC of 14-O-clarithromycin. Clarithromycin may be administered without dosage adjustment to patients with normal renal function taking ritonavir. However, for patients with renal impairment, dosage adjustments should be considered. Overdosage. Overdose of clarithromycin can cause gastrointestinal symptoms such as abdominal pain, vomiting, nausea, and diarrhea. Adverse reactions accompanying overdosage should be treated by the prompt elimination of unabsorbed drug and support IV measures. As with other macrolides, clarithromycin serum concentrations are not expected to be appreciably affected by hemodialysis or peritoneal dialysis. How supplied? Clarithromycin tablets 250 mg are available in blister pack of 10s. Clarithromycin tablets 500 mg are available in blister pack of 10s. Clarithromycin granules 125 mg per 5 ml are available in 50 ml. Clarithromycin drops 125 mg per 5 ml are available in 25 ml. Clarithromycin dry suspension 250 mg per 5 ml are available in 70 ml. Storage. Store below 30 degrees centigrade. Protect from sunlight and moisture. The reconstituted suspension can be used for up to 14 days, when stored at room temperature. The expiration date refers to the product correctly stored at the required conditions. Keep out of reach of children. To be sold on prescription of a registered medical practitioner only. Thanks for watching my video. Please like and subscribe my channel. Thank you again.